Hello, everyone. Are you guys able to hear me? Hey, Cheryl. Hey, Monisha. Hey, Ashley. Hey, Walden. Okay, Francis, you're here. You weren't here last week, so I'm glad you're here this week. All right, guys. Today we have an action-packed lesson. So let's go ahead and get started. Let me first share my screen. We've been through this before, where I think I'm sharing my screen and I'm not. Okay. All right, that should be better. Are you guys able to see my slide? Okay, all right, wonderful. So let's go ahead and get started. All right, so our agenda for today is going to be chapter 75, which is Enterobacteriaceae, chapter 84, which is Legionella, and chapter 97, viral hepatitis. We're only doing questions for the viral hepatitis chapter. I'm going to find ways to kind of put some of these diseases that are very commonly asked about in the exam into other portions of our studies. So like you'll continuously see hepatitis, you'll continuously see tuberculosis, because those are diseases that are really important to know. So just because we've already covered them doesn't necessarily mean you're not going to see them in other types of questions. Okay, so this is where we are right here. We're on week 4. And your assigned readings for this week were the following. I know it was a lot. It was a pretty heavy week of reading for you all. For those of you who are doing your readings, for those of you who aren't, get it together, people. Okay, so let's get started with Enterobacteriaceae. So, Enterobacteriaceae are healthcare-associated infections with members of the Enterobacteriaceae family. Are among the most life-threatening, preventable, and costly infections encountered in healthcare facilities. So can you guys share some general facts that you know about Enterobacteriaceae that you may have read about or that you just know from your experience working in hospitals or working in public health? Okay, that they're gram-negative, correct. A lot of resistance. Yeah, the multi-drug resistance, facultative anaerobes. They're found in our colon. Okay, I see a lot of people putting resistance. Wonderful. Now, can you guys tell me if Enterococci and Enterobacteriaceae are the same thing? Or if there's a difference that y'all know about? And if there are any microbiologists on the line, is it Enterococci or Enterococci? Enterococci is answer A, or pronunciation A. Enterococci is pronunciation B. I don't know if you guys know, just so that I can get my life together. Okay, so one of you says that they're not the same. Very good, Cheryl. So Cheryl said they're not the same. One is gram positive versus the other one who is gram negative. Very well. A lot of times people get these two confused, and it's really important to just make sure that you realize when you're speaking with laboratorians or other people in your hospitals that they understand you're not speaking about the same pathogen or organism. Okay, so true or false? Enterobacteriaceae are gram-positive organisms. Very good. Everyone is putting false. Yes. Now, Enterobacteriaceae are natural inhabitants. Oh, the answer is false. We should get used to knowing when these different types of bacterial families come up, whether they're gram-positive, gram-negative. But let's move on to question 2. Enterobacteriaceae are natural inhabitants of A, the lungs, B, urinary tract, C, GI tract, and D, skin. Okay. Right, so most commonly your Enterobacteriaceae are going to be your natural inhabitants of the large intestines of humans and animals, and they can also inhabit soil, plants, and water. And because of their affinity to the GI tract, you can often refer to them as enterics or coliforms. And so that's that, so that we can kind of get acquainted a little bit. So Enterobacteriaceae characteristics. So they're ubiquitous. They can be found in our environment. They can be found in our gut. And so they're pretty much all over the place. There's really no way of avoiding them. They cause about 1/3, so 30 to 35% of the bacteremias and more than 80% of the UTIs, right, in healthcare. They're non-spore forming gram-negative rods. They have a common antigen on their cell wall, the enterobacterial common antigen, ECA, which allows them to all be classified under the Enterobacteriaceae family. They're facultative anaerobes, which we should know what that is by now. You will know what a facultative anaerobe is by the end of class, because I ask you, I think, every single week. A lot of the times, your laboratorians are going to use McConkey agar to differentiate and to grow these types of gram-negative bacteria, and they can either be lactose fermenters or non-lactose fermenters. Now, this is McConkey agar. So we have on the left-hand side the lactose fermenting colonies, and then on the right-hand side the non-lactose fermenting colonies. So what we need to know about McConkey agar is that it's a selective and differential medium designed to isolate and differentiate enterics based on their ability to ferment lactose. So this type of agar has bile salts and crystal violet to inhibit the growth of gram-positive organisms, which is why you're really utilizing this specific type of agar to basically pick out your gram-negative organisms. And this is what it looks like, okay? Now, McConkey agar is selective media plus differential media. And so essentially what that means is that it contains chemicals that inhibit normal commensal bacteria, and it stains colonies of specific organisms while inhibiting the growth of others, right? And once again, you have a really pretty picture here, so that when you read this in the text, I don't want you to just be reading like, oh, okay, McConkey agar, catalase positive, this, and that. Like, you should be wanting to know what it looks like and having an idea in your brain so that you can be like, yes, I remember this. And I think visual aids can really help you put this into perspective for when you're taking your exam. So with Enterobacteriaceae, you have basically your lactose fermenters and your non-lactose fermenters. In the lactose fermenter side, you're going to have your E. coli, which is motile, meaning that it moves, and your Klebsiella pneumoniae, which is non-motile, right? Your non-lactose fermenters, you have non-motile Shigella and Yersinia. Now, besides Yersinia pestis, which we know causes plague, what is another Yersinia that we've come across in class before? I'll give you a clue. It starts with an E. Okay, we have no answer. So Yersinia enterocolytic. Oh, Esther! Yes, Esther. Very good. Okay. You too, Angela. Beautiful. Okay, so they said Yersinia enterocolytica. Very good, very good. And then for the motile side, we have Salmonella and Proteus. I do have to make a quick edit. In one of my previous presentations, I was talking about Pseudomonas aeruginosa and Proteus, and during that lecture, I mentioned, well, we know Pseudomonas Pseudomonas aeruginosa and Proteus aren't Enterobacteriaceae, and that was my mistake because Pseudomonas is not an Enterobacteriaceae, but Proteus is. So I do apologize. But once again, we have them split up into our lactose, non-lactose fermenters. For our motile non-lactose fermenters, we have Salmonella and Proteus. And Proteus is a common cause of blank, specifically in nursing homes, in male patients in nursing homes. Elizabeth, very good. UTIs. Yes, urinary tract infections. You'll often find Proteus associated with UTIs in some of the patients or residents in nursing homes. So that's part of your UTI chapter, which you have not read yet, but I'm just letting you guys know. Oh, ooh. I apologize. Okay, and then here we have some growth of Enterobacteriaceae on McConkey agar. You have an uninoculated plate, and then you have some of your lactose non-fermenters such as Salmonella, Shigella, and Proteus. And Salmonella is a lactose fermenter, but it just does it really, really slowly. So, you know. And then your lactose fermenters, E. coli, Citrobacter, Klebsiella, and Enterobacter. All right, question 3. Enterobacteriaceae are associated most often with which of the following healthcare-associated infections? 1. Pneumonias. 2. Surgical site infections. 3. Bacteremia. And 4. Urinary tract infections. And then you have the following answer choices below. And this is a real easy question if you did your reading. Okay, we have a mix. We have some C's, but we do have a lot of D's. Very good. Okay, so they actually do. Oh, I didn't highlight this one. I apologize. So the correct answer is D, 1, 2, and 3. They are known to cause all of these infections, and that's what they're associated with. When you read through your text, I think it's on the second or third page that they go through what different types of healthcare-associated infections Enterobacteriaceae are most common associated with. The most familiar species recover from extra-intestinal diseases, meaning outside of the gut, are E. coli, Enterobacter cloacae, Klebsiella pneumoniae, Serratia marcescens, and Proteus mirabilis. Salmonella species and Shigella species and E. coli are common agents of gastroenteritis and colitis. Now let's have a little bit of a bonus question. There are 2 species of Salmonella for which humans are the only reservoirs. What are those 2 species? Or if you only know one, that's okay. Our epis are coming out in full force. Yes, you guys are correct. So Salmonella typhi and Salmonella paratyphi. That is correct. So asymptomatic carriers of Salmonella typhi and Salmonella paratyphi strains may be maintained in the carrier state by humans, and about 1 to 5% of patients will become chronic carriers. All right. So we're going back to this drawing, and I hope that you guys dream about this drawing of your gram-positive and your gram-negative cell walls of your bacteria. So we're sticking more on the right-hand side of this PowerPoint for today, so learning a little bit more about our gram-negatives. So an important portion of gram-negative organisms, and specifically relating to your Enterobacteriaceae, is that those lipopolysaccharides, which are in the cell wall, right? There are 3 major components of LPS, which are your O polysaccharide, your core polysaccharide, and lipid A. Now, since we know that this is found in the cell wall, would that make LPS and these different components an endotoxin or an exotoxin? I'll repeat it. So since LPS is found in the cell wall of the gram-negative organisms, is it considered an endotoxin or an exotoxin? Okay. Yeah, the majority of you are saying endotoxin, which is correct. That is correct because your endotoxins are going to be associated with your cell wall. I can't remember who it was that told us that exotoxins exit the cell. So your endotoxins are going to be attached to that cell wall. They're not inside the cell and then exiting, okay? So LPS is a heat-stable product in the cell wall that's actually recognized by CD14 on macrophages and allows for the cells to be phagocytized. And lipid A, which is one of our major components, it's actually what causes the inflammatory effects of LPS. So when you have that increased cytokine production and fevers, that's lipid A that is doing that. It causes fever, shock, disseminated intravascular coagulation, and once again, lipid A is an endotoxin. Oh, Elizabeth, yes, it was you. Elizabeth Rowan was the one who taught us that in one of our previous lessons. So that's what we're here for, guys, collaboration. So question 7, which of the following virulent factors associated with the Enterobacteriaceae are associated with septic shock and DIC? Flagellar H antigens, capsule K antigens, pathogenic islands, LPS polysaccharides, and lipid A endotoxin. Good, very good. Now, I wouldn't necessarily, I personally would not spend a lot of time memorizing a lot of these different types of mechanisms of action. I feel like you may get some questions on them, but from my experience, I feel like a lot of the questions are more kind of high level, but I just think it's important for you guys to know this because it helps you understand the pathogenesis of these diseases better, and it helps you understand different bacteria um, in a more like specific way, if that makes sense. So once again, we already talked about LPS, polysaccharides, and lipid A. And these are the different other types of factors that can be utilized. So for example, for flagellar H antigens, they facilitate motility and adherence to the GI and urinary epithelial cells, and they also assist in the invasion of mucosa. So you can see how these gram-negative Enterobacteriaceae with these different factors can be so deadly and cause such bad diseases because of all of these different types of factors which allow them to invade our bodies. Now, serological classification is based on the presence and detection of the O, K, and H antigens. Differential combinations of these antigens within and between species allow for great antigenic diversity and gradient of pathogenicity. All right, we have question 4. Ms. Smith is a 75-year-old female with a past medical history of breast cancer, COPD, alcoholism, and liver cirrhosis. She was admitted to your ICU with a high fever and diagnosis of shortness of breath. Her chest x-ray revealed a primary lobar pneumonia. For the past 2 days, her sputum has had a red currant jelly appearance. Her sputum culture is still being processed in the lab. Based on her past medical history and her current symptomology, what pathogen do you suspect? A. E. coli, B. Klebsiella pneumoniae, C. Enterobacter cloacae, and D. Serratia marcescens. Okay, we have the majority of you guys are getting this one right. We did have some people who were a little bit unsure. The majority of you did put Klebsiella pneumoniae, which is the correct answer. So Klebsiella pneumoniae has been commonly, like the pneumonia has been commonly associated with a red currant jelly type of sputum that the patients are spitting up. Um, and it's really it's not cute. And so that was kind of the key terminology in that specific. Is this product real? I don't think so. I hope not. I hope it's not real, Maria. But hopefully this will make you remember the red currant jelly in case they ask you about red currant jelly on your exam. Now, at the end of our lecture today, I am going to be playing this sketchy micro video, which is extremely helpful in helping you remember Klebsiella, Enterobacter, and Serratia. So that'll be kind of like an extra portion of our lesson today, because I think it's a really great video, which they use different ways of helping you remember these microbes. So for example, they use this oxygen here to represent that the patient has pneumonia. They use, this Foley and this bag to basically represent that the patient has a UTI. And so it's just so fun. Their videos are so great. Okay, so treatment of Klebsiella infections have become problematic in several regions of the country due to increasing prevalence of carbapenemase-producing strains, and these strains produce broad-spectrum beta-lactamases that inactivate all beta-lactams. So can we talk about what some of the common antibiotics under the class beta-lactam are? Penicillin, okay, cephalosporins, monobactams, what else? Carbapenems. All right. So beta-lactam antibiotics are a class of broad-spectrum antibiotics consisting of all antibiotic agents that contain a beta-lactam ring in their molecular structures. This includes penicillin derivatives, cephalosporins, monobactams, and carbapenems. So very good. You guys got all of them. Now, carbapenem-resistant Klebsiella pneumoniae is the most frequently isolated carbapenemase-producing Enterobacteriaceae. So it's pretty common, and I'm sure you guys have seen KPC, you know, Klebsiella pneumoniae, carbapenemase on your Klebsiella pneumoniae. It's Inception, right? So Inception like the movie, like anyways, I'm sorry, it made sense to me. Maybe it won't make sense to you. So moving on. Question 5. Question 5. Yes, Maria, it is a good movie. Um, David is a 3-year-old male presenting to the ED with symptoms of abdominal cramping and watery diarrhea for 12 hours. Upon physical examination, the patient appears lethargic, has diffuse abdominal tenderness, and has dry mucous membranes. While examining the patient, he has had a bowel movement of watery diarrhea that is grossly bloody. The mother is unable to state when the patient's last urine output occurred. The patient's laboratory workup reveals a HNH of 7 and 18. The patient is in acute kidney failure and has a low platelet count. What pathogen do you suspect? You should be able to start picking these types of scenarios apart, right? Taking away what some of those key things are. We know that it's an Enterobacteriaceae, right? Because we're learning about Enterobacteriaceae. So what does this sound like? A patient whose mucous membranes are dry, grossly bloody diarrhea. Mom doesn't know when the last urine output is. What does that tell us about that patient's kidneys? Right, right, right. Very good, very good. You guys got it. All right. So we're dealing with E. coli O157H7. So this is a complication, hemolytic uremic syndrome. Right? We know what this is. Acute renal failure, very good. Their kidneys are failing. Yes, so you should have, read about this and known. Yeah, I immediately can recognize that. I know what we're dealing with here. And this is just about getting familiar with these pathogens and being able to recognize them. Right? So some of the common sources of this pathogen are going to be uncooked or raw hamburgers, milk, apples, cider, person to person in daycares and nursing homes, and that's referring to transmission. So what is the most common complication of E. coli O1, E. coli O17H57 among the, sorry, yes, E. coli O157H7 among the elderly. What is the most common complication among the elderly? Not children, but the elderly. We have shock, UTI, septic shock. So it's going to be thrombotic thrombocytopenia purpura. All right, that was just a little bit of a fun question. All right, so members of the family Enterobacteriaceae include gram-negative shark coccobacilli or straight non-spore-forming bacilli. These organisms are facultative anaerobes, so please define a facultative anaerobe. Out of this picture, which one of these is a facultative anaerobe? A, B, C, D, or E? Once again, which one of these is a facultative anaerobe? Starting from the left, we have A, B, C, D, or E? Oh, So this is not a concept that we have solidified yet because we have a lot of B's and D's. A lot of D's. Interesting. All right. So with our facultative anaerobes, they are both aerobic and anaerobic growth, and they have greater growth in the presence of oxygen. So growth is best where most oxygen is present, but it occurs throughout the tube. So a facultative anaerobe is an organism that makes ATP by aerobic respiration if oxygen is present, but is capable of switching to fermentation or anaerobic respiration if oxygen is absent. Y'all gotta know this. You guys have to know this. I have shown this chart many, many times. We need to be getting 100% on these questions. All right, question 8. Sorry. Question 8. BSIs or bacteremias caused by the Enterobacteriaceae are usually a result of contiguous spread from the urinary tract, lungs, or GI tract. Other portals of entry include surgical sites, decubiti, and central venous lines. In the latest data from NHSN 2009 to 2010, they accounted for 19.6% of infections. Which of the following was the most commonly associated with bloodstream infections? Can you guys hear me? Are you guys able to hear me or no? Yes? Okay. Okay. I'm not sure what happened there. Thinking. Okay, so some of you guys are thinking. All right. Okay, so let's see what they tell us. So we're dealing with which of the following was most commonly associated with BSIs. BSIs. Clabsies, right? Clabsies is this one. Which one has the highest number, right? Exactly, K pneumoniae. Now, I know K pneumonia is down here for our clabsies right here, which is the correct answer, which was A. However, I did want to point out that Enterobacteriaceae are the leading cause of caries in the 2009 to 2010 NHSN survey, and E. coli was the top pathogen recovered from caries. So while K pneumoniae, we're dealing mostly with clabsies, as far as your urinary tract infections, you always want to remember E. coli. E. coli, E. coli, E. coli for your urinary tract infections, clabsies, K pneumoniae. It's just the reason why I wanted to point that out here is because I feel like this graph does such a good job of just showing you how disproportionate E. coli is in comparison to these other types of species, right? Or these other bugs. It's literally through the roof. And it's really interesting. All right. Our next question. A 10-year-old boy is admitted to the hospital with a 3-day history of fever, abdominal pain, diarrhea, and vomiting. He and his family have just returned from a week-long camping expedition in the mountains that included trips to the seashore. A stool culture is reported with many lactose-negative colonies. Which of the following is the most probable causing organism? A. Providencia, B. Rotavirus, C. Yersinia, and D. Shigella. Many lactose negative colonies. Think of your Enterobacteriaceae, non-lactose fermenters. Which one was on that side? All right. So Yersinia enterocolytica, we know that that one is a non-lactose fermenter. This is from chapter 79, so I wanted to be sure to include this in your in today's presentation because unfortunately we just do not have time to go through that chapter. It is way too dense, and it would take us a whole day. So I just wanted to throw in this bonus question here for chapter 79. Okay, so true or false? Luce, you done messed up. I apologize, my animation was not on point. So let's just go through these. True or false? Members of the Enterobacteriaceae family include gram-negative short coccobacillary or straight non-spore forming bacilli that grow well in the presence or absence of oxygen, which means an facultative anaerobe. And then the emergence of carbapenemase producing Enterobacteriaceae is a mounting public health concern. Both of these are true. Additionally, carbapenemase enzymes have broad spectrum hydrolyzing activity, which basically renders all penicillins, cephalosporins, and carbapenems ineffective. These types of carbapenemases, they can often be found on mobile genetic elements, which can lead to multi-drug resistance. So this is, when I was asking you guys, what do you know about, gram-negative organisms? And you were all saying, oh, we know that they are resistant. This has a lot to do with that. All right, so next chapter is Legionella. So the background, it was identified in 1976 at the American Legion Convention held in Philadelphia, Pennsylvania hotel. They are aerobic gram-negative fastidious bacteria. So aerobic means that they like what? They like something. Very good. They like oxygen. They are fastidious. What does fastidious mean? Particular? That's not specifically what I'm looking. Oh, Maria, fastidioso. So yes. Okay, who is this? Gina D'Ambrosio. Hard to grow. Very good. Yes, they are difficult to grow. They require specialized culture media, and they're often detected utilizing an urinary antigen test. Legionnaire's disease causes pneumonia, and your Pontiac fever causes a flu-like illness. And the CDC estimates that less than 5% of cases are diagnosed and reported to the CDC. And here we have a beautiful picture of our gram-negative Legionella. And here we have a picture of that fastidious aspect of it, where you need to grow it on a specialized culture media. All right, so our clinical presentation for Legionnaire's disease, you have an incubation period of about 2 to 10 days, and some of the associated symptoms are non-productive cough, a fever, which can usually exceed 104, shortness of breath, malaise, myalgias, anorexia, headache, confusion, watery diarrhea, nausea, vomiting, and abdominal pain. That kind of sounds like it could be anything. So they're very non-specific symptoms, right? As far as your labs go, one indication is going to be hyponatremia. Now, what does hyponatremia mean? What's the definition? Angela, you are just quick today. All right, she said low sodium levels. Yes, it occurs when the concentration of sodium in your blood is abnormally low. Now, as we know, sodium is an electrolyte, and it really helps to regulate the amount of water that's in and around your cells. And your chest x-ray is going to show infiltrates. Now, the clinical presentation for Pontiac fever is different. So the incubation period is about 24 to 48 hours. You have high fevers, chills, myalgias, and headaches, but symptoms usually resolve within 2 to 5 days. So if you were going to get one of the two, you probably want to get Pontiac fever. This is basically a comparison, right, between Legionnaire's disease and Pontiac fever. So for Legionnaire's disease, you have the portal of entries respiratory, bronchopneumonia, you may have bacteremia, and it may vary from mild to severe fulminant systemic disease and death. This is serious. As far as Pontiac fever, it's self-limited, it's not particularly fatal, there's no pneumonia, and you can be asymptomatic, and you typically recover in 2 to 5 days. So I'd take Pontiac fever, but that's just me. As far as risk factors, some of the risk factors for Legionnaire's disease, it's going to be advanced age, male gender, cigarette smoking, alcohol abuse, chronic pulmonary disease, immunosuppressed hosts, renal failure, and corticosteroid usage. These are some of the risk factors that people, unfortunately, if you have these, it's going to make it a lot easier for the bacteria to infect you, to get into your lungs, to wreak havoc, to make you have a bad day, and some pretty terrible symptoms. Now, as far as the pathogenesis, so it is its natural habitat is water, right? It loves water. It's a water-loving bug. What's another one of our water-loving bugs? One of my favorites. Starts with a P. Pseudomonas, yes. Thank you, Danielle. You know me well. Pseudomonas, yes. Pseudomonas aeruginosa. It's one of my favorite bugs, and they are water-loving. As far as the mode of transmission is via direct inhalation or aspiration. Person-to-person transmission does not occur. Now, they state that in the book, but let's just get this out there for all of us to know so that we can all be, aware. There was one reported case in Portugal. And essentially what happened is this 48-year-old man that lived in Portugal, he was a smoker who basically worked as a maintenance worker at an industrial cooling tower in Portugal. He ended up getting Legionella. They did identify that the cooling tower complex, it was contaminated with Legionella pneumophila. And he came home, he wasn't feeling well, he lived with his mother, and he began to have this like really intense cough, fevers, and his mom was trying to take care of him like all mothers should, and unfortunately he ended up having to go to the hospital like not too long after he started to experience these symptoms because he was doing really bad. They had to put him on ECMO, and what essentially happened was that his mom, who was 74 years old, a couple of days later, she began to report fevers, cough, loss of appetite, and then she had septic shock due to pneumonia. And unfortunately, both patients expired. So both the son and the mother did die. And that was a person-to-person case, which was documented in Portugal that we know of. No other cases have really been published. And if they have, then, feel free to share that with me. I'll distribute it to the group if you know of any other cases. But that's just a little bit of background on that person-to-person transmission. As far as aerosolizing by use of respiratory tract devices like humidifiers and nebulizers, they didn't drink the same water source. Esther, they did not mention that in the article. But I have it linked right here so you can go through it, Esther. It's actually really interesting if you want to learn a little bit more about it. All right, so Legionella infections can be trained to multi-species biofilms. So what we have here is a beautiful picture of a biofilm, right? And this is where Legionella hang out. This is where they thrive. This is the situation station that y'all need to know about. So Legionella, they love to live inside these little protozoa. They are just happy as they can be in biofilms. They reproduce, they munch, they grow, and then, something happens and they move down further and start colonizing other parts of the pipe, and that's how they're able to get into drinking water systems, right? And um, Legionella are released from the biofilm and can enter into the drinking water or recolonize biofilms downstream. So it's actually pretty difficult to get rid of some of these biofilms. And you can see some pictures here of what that biofilm looks like. And, you know, I wonder what my pipes look like at home. Just curious. But let's go over some key facts. So diagnosing Legionella, you want to make sure that there's clinical awareness when it comes to being able to diagnose Legionella, right? If your physicians, if your mid-levels aren't aware that this is something that they should be looking for, they're not going to do it, right? They're not going to order the test. It's not even going to, Legionella, from my experience, it's like the last thing on the differential. It's like they've gone through all of oh, it's not this type of pneumonia. It's not this, it's not that. Well, shoot, what could it be? It's probably, gonna be Legionella, right? Now, some definitive tests, isolation of organisms by culture. You have specimens, you can do sputum, lung tissue, pleural fluid, tracheal aspirate, bronchial washings, PFG testing for subtyping, urinary antigen test, and most common limitation is that you're only able to detect Legionella pneumophila serogroup 1. And as far as treatment, you have quinolones, levofloxacin, Cipro, and the macrolides, which are azithromycin, and the therapy duration is usually 10 to 14 days. Okay, so I hope that kind of clears it up a bit. Now, some prevention strategies. So you want to make sure that you have a water safety plan. A lot of healthcare facilities contract out to companies to do their water safety and water management programs, but other facilities like nursing homes or even hospitals, they may not be contracting out. They may be coming up with their own water safety plans. Now, as far as disinfection systems, you have different options. You can superheat and flush, hyperchlorination, copper silver ionization systems, chlorine dioxide, monochloramines, and point of use filters. Now, this is important for you to know as an infection preventionist, right? If you're an IP, if the health department is going to come into your facility, some of the things that we're going to be looking for is going to be your water system. We're going to ask you, hey, can you walk us through the water flow in your facility? Where does it come in? Where is the patient, that was diagnosed with Legionella? Where is his room? Where along the water distribution line does this patient, live? By the time the water gets from the heater to the patient's room, what temperature are we at? So this is why it's so important for you to be familiar with this terminology. And there is a separate chapter on water management where we'll dive a little bit more into this. But there are a lot of different avenues that facilities can utilize and disinfection systems that they can utilize to include in their water safety plan. All right, so question 1. Pneumonia that develops 40 hours after hospitalization in a patient without previous healthcare contact for 6 months but with current oxygen therapy would be classified as A, healthcare-associated pneumonia, B, hospital-acquired pneumonia, C, community-acquired pneumonia, and D, ventilator-associated pneumonia. Okay, we have a mix. We have basically every answer up on this board. C, B, A, all of them. All of them are up here. All right, so the correct answer for this one is community-acquired pneumonia. These definitions are important. So pneumonia that develops 40 hours after hospitalization in a patient without previous healthcare contact for 6 months, but with current oxygen therapy would be classified as community-acquired because the patient was admitted from the community and pneumonia occurred less than 48 hours after admission. All right, that's just a straight up definition. Either you know it or you don't. Some of these questions you're really kind of able to work with and try to cross them off, but some of the questions, unfortunately, they're going to be just straight up memorization. Do you know the definition for this? Do you not? And that's how you'll have to do it. Now, the most common cause of community-acquired pneumonia in adults is A, methicillin-resistant Staph aureus, B, Haemophilus influenza, C, Mycoplasma pneumoniae, and D, Streptococcus pneumoniae. Interesting. We have a lot of different answers here as well. Oh goodness. Okay. All right. Every answer is up on here, but the one that seems to be winning is D. It's between B or D. Those are the most commonly stated. And D is correct. So Streptococcus pneumoniae is going to be the causative agent for adults with pneumonia 20 to 50% of the time, or the cases. Mycoplasma pneumonia is about 20 to 30% of cases. Community-acquired methicillin-resistant Staph aureus is relatively rare, and Haemophilus influenza is an increased risk in children and older adults, but not adults, right? So it's either end of the spectrum, not the middle. Perfect. All right, the current community-acquired pneumonia, CIP, national quality measures used in the United States include all of the following except A, antibiotic timing within 6 hours of arrival, B, antibiotic selection, C, blood cultures performed in the emergency department before antibiotics were administered, and D, ensure that all patients are screened for pneumococcal vaccine. All right. Ooh. This one is mixed. We have a lot of different answers, right? Someone just said, I'm guessing today. Okay, so the current community-acquired pneumonia national quality measures used in the United States include all of the following, except this one's tricky. All right, this one's tricky. I'm not gonna lie to you because it's such a minute detail that many of you might be overlooking it. So the core quality measures set of standards defined by the Joint Commission and CMS for community-acquired pneumonia include the following: oxygen assessment within 24 hours before or after arrival at the hospital, patients over 65 screened for pneumococcal vaccination and administration before discharge if necessary, that blood cultures are performed in the ED before antibiotics were administered, that antibiotic timing within 6 hours of the arrival, antibiotic selection, adult smoking cessation advice and counseling provided, and the influenza vaccination. So the only one that was incorrect was that ensure that all patients are screened for pneumococcal vaccine. And like I said, this one was tricky, but hopefully you'll remember it for the future. The the thing here is that all patients do not need to be screened, only your patients that are over 65, okay? All right, there is an outbreak of waterborne pathogens in your healthcare facility, but the only information you have about this outbreak is that it is related to contaminated equipment. Based on that knowledge, which of the following organisms would be more likely to be the cause of the outbreak? A. Cryptosporidium parvum, B. Legionella pneumophila, C. Pseudomonas aeruginosa, and D. Mycobacterium tuberculosis. When you're reading this question, two things should be immediately popping out to you. You should be highlighting this in your brain. Number one is that this is an outbreak of a waterborne pathogen. So we know our answer is a water-loving bug. And number two is that it is related to contaminated equipment, right? It's related to contaminated equipment. It loves water. And I'm sorry, you guys are so funny. Yes, it loves water and it is related to contaminated equipment. Well, it's no surprise here that I chose this question because the correct answer is Pseudomonas aeruginosa, and Pseudomonas aeruginosa is Bay. So Pseudomonas and non-tuberculosis mycobacteria are the waterborne pathogens that are most commonly associated with outbreaks related to contaminated equipment. I'm going to say it one more time for the people in the back. Pseudomonas and non-tuberculosis mycobacteria are the waterborne pathogens that are most commonly associated with outbreaks related to contaminated equipment. Tap water that is used to rinse instruments after disinfection and as a water source for medical instruments may be a source of these infections. Very good, very good. Let's keep it moving. Question 5. A patient has been diagnosed with Legionnaire's disease that was possibly acquired during his stay in the hospital. What is the recommended first response to this incident? Now, my public health people, put on your IP hats, okay? So once again, you just had a patient, they got diagnosed with Legionnaire's disease. What is the first thing that you're going to do in response to this? A, all water sites in the healthcare facility to which the patient was exposed should be cultured for Legionella pneumophila. B, the patient should be placed on respiratory isolation until 24 hours after treatment has started. C, the water system should be superheated and flushed immediately. Oh, that should be a B. D, all patients should immediately be provided with bottled water for drinking. Oh, we have a lot of B's. We have a lot of B's. Interesting. Okay, I'm gonna give you guys one more minute because I need more participation. Let's get in here, people. Let's put in these answers. Okay. I only had a couple people choose D. Okay. All right. So let's read through this. Legionnaire's disease, key thing that we're looking at here. identified while they're at the hospital, what do you do first? So, B, the patient should be placed on respiratory isolation until 24 hours after treatment has started. We can cross that one out, right? Because what do we know about Legionnaires? It is not transmitted person to person besides that one case in Portugal. And because there's only just been one case, we do not consider that this disease is transmitted person to person, right? The literature doesn't support it. The water system should be superheated and flushed immediately as a prevention measure. Yeah, that could be it. That could be it. So C, possibility. D, all patients should immediately be provided with bottled water for drinking. We know that Legionnaires needs to be through inhalation, right? So it needs to be inhaled into the lungs, right? So unless you have a patient who has dysphagia or who has other issues with swallowing, yes, aspiration. Very good, Terry. Thank you for correcting me. Yes, aspiration. It needs to be aspirated into the lungs. So all patients should immediately be provided with bottled water for drinking. That one doesn't really make sense, right? So we're stuck between A and C. And per your APIC text, right? Per your APIC text, because remember, you need to be following the APIC text if you want to pass this exam. All water sites in healthcare facilities to which the patient was exposed should be cultured for Legionella pneumophila, right? Water systems should be tested first to determine whether the microbe is present. So this is straight from the textbook. Now, if you guys have some time, I love podcasts, I love YouTube. If you guys have time, make sure that you listen to Sawbones. They have an episode on Legionnaire's disease, and they talk about the history of Legionnaire's disease. They talk about how the CDC responded to it, how they sent 20 epidemiologists out to investigate this. They had no idea what it was. And I'm just thinking right now of that type of response, like imagining 20 of us going out somewhere to investigate something that we're completely unsure of what it is. That must have been so insane for those people who were actually there doing it and trying to figure it out. So it is a little bit of a longer podcast, but if you guys are driving home, I've listened to this specific podcast like 3 times. I listened to it on my way to work today, and it was really good. And it's just kind of like a fun podcast. It's not something that's overly scientific. It's really fun. Okay, now this last section is all questions. So viral hepatitis. Higher morbidity rates in chronic hepatitis B virus carriers are associated with a co-infection of A, enteric NA/NB hepatitis, B, hepatitis C, C, hepatitis D, and D, hepatitis E. Higher morbidity rates in chronic hep B carriers are associated with a co-infection of the following. Danielle Walden is like, I know this. She said the answer is C, hep D. Very good, Danielle. That is correct. So hepatitis D, also known as delta hepatitis, is a serious liver disease caused by infection with the hepatitis D virus, which is an RNA virus structurally unrelated to the hepatitis A, B, or C viruses. HDV is an incomplete virus that requires the helper function of hepatitis V to replicate and only occurs among people who are infected with the hepatitis B virus. HDV is transmitted through percutaneous or mucosal contact with infectious blood and can be acquired either as a co-infection with HBV or as a superinfection in persons with HBV infection. Both superinfection and co-infection with hepatitis D virus results in more severe complications compared to infections with hepatitis B alone. In combination with hepatitis B virus, hepatitis D has the highest mortality rate of all the hepatitis infections at 20%. Okay? So, don't forget it. Hepatitis B, you need hepatitis D. Only a few of you answered that question, so it's important for you guys to know this one. Question 2. For a labor and delivery nursery employee, which of the following would be most important to provide protection to the nurse from infectious disease? A, chickenpox or shingles history, B, tetanus, diphtheria, immunization status, C, measles, mumps, rubella, immune status, and D, hepatitis B immunity. Let's see. D, we have a lot of Ds. Very good. It's hepatitis B immunity. So this has a little bit more to do with your occupational health, but I wanted to include it in here because you guys need to understand that you're going to get like epi and pathophysiology questions on these diseases, but they're also going to find ways to tie it into your occupational health, right? So it's really important for you guys to be familiar with this. So all healthcare workers are at risk for occupational exposure to blood or blood-contaminated bodily fluids. The CDC recommends that all healthcare professionals, first responders, and others who are at risk for blood exposures on the job be vaccinated against hepatitis B. Furthermore, OSHA federal standard requires employers to offer hepatitis B vaccine free of charge to employees who are occupationally exposed to blood or other potentially infectious materials. All of these other diseases are important. It's important for you to have immunity to them, but for a labor and delivery nurse, when you're giving birth, or so I hear, there's a lot of blood involved, right? So this is why it's hepatitis B. Question 3, the laboratory notifies you that a patient on the nursing unit has a positive hepatitis A antibody IgM. Which of the following is true? A, the nurse should be immunized with immunoglobulin. B, the patient is immune but has had hepatitis A in the recent past. C, the patient has had hepatitis A sometime in his lifetime, time unknown. D, the patient is infectious. And if you know your immunoglobulins, then you know the answer and you don't even have to read this twice, right? We went over our immunoglobulins before, right? So with IgM, what's the difference between IgM and IgG? When you come into contact with a pathogen, right, and your body develops immunity, what are the main differences between IgM and IgG? Right. Very good. So acute versus chronic, active infection versus immunity. Very good. So IgM is going to be that first antibody to be produced in the body in response to an infection. The IgM antibodies, they occur later on. So if you were to draw kind of like a reaction curve, your IgM would start going up first, right? And then eventually they would come back down. And sometime around here, you would start to see your IgM start to increase, and then they can, they can stay up for a certain amount of period, for a certain period of time, right? I wish I had a little pen to draw on here. It would be so much fun. Okay, question 4. An employee who has received all 3 doses of hepatitis B vaccine and who has never had hepatitis B virus infection would be expected to have which of the following serological markers? A, B, C, or D? Our epi people are coming out strong. All of the epis are putting the correct answers. Very good. Yes. Yes, it is A, hepatitis B surface antibody, right? Because the vaccine has that surface antigen, right? That is able to recognize it, and that's how you develop that immunity. What does the E stand for? Envelope. Very good. What about the C? What does the C stand for? Core. And the only way you're going to have an E or a C is if you've been infected, because that's what is in the virus, right? You have to have had infection, and it tells you right here that he has never had hepatitis B. So we can easily cross off B, C, and D. So if we just know that alone, we're able to get to the answer. Okay, let me check my time. How many more questions do we have? Okay, we have 2 more questions. So, a hemodialysis patient who has a positive hepatitis B surface antigen has just been admitted to the surgical floor for evaluation of abdominal pain. His next treatment is scheduled for the following day. The inpatient dialysis unit does not have an isolation room. The supervisor has requested your assistance in developing a plan to provide the treatment in the safest location. After reviewing the Centers for Disease Control and Prevention guidelines, your recommendations are: A, if staff members are anti-HB positive, no special precautions are required. B, the patient will need to be transferred to the outpatient unit for dialysis. C, the patient should receive treatment in a private room using dedicated equipment. And D, the treatment can be done in the inpatient unit using standard precautions. Very good, you guys are all putting C. So the CDC recommends that patients admitted to the acute care setting should undergo dialysis in a separate room and using a separate machine, equipment, instruments, and supplies designated only for hepatitis B surface antigen positive patients. Dialysis staff caring for these patients during treatment should not care for hepatitis B virus susceptible patients at the same time. Okay, during an in-service program for new employees, the IP describes how hepatitis B and HIV are transmitted. A major difference in the epidemiology of the two diseases is A, the ease of transmission through needle punctures, B, the potential for airborne transmission, C, the presence of the causative agent in various body fluids, and D, the ability of the diseases to be transmitted during sexual intercourse. I apologize for my typos, guys. So I'll let you marinate. Let that question marinate. Good job, Cheryl. Shout out to Cheryl with Florida Hospital. She said A, the ease of transmission through needle punctures, which is correct. So the risk of hepatitis B virus seroconversion after a percutaneous injury ranges from 23 to 64%. 23 to 64%. That is significantly higher than HIV, which I think is 0.03%. All right. Last question. Hepatitis A is diagnosed by the presence of A, immunoglobulin G for anti-hepatitis D virus, B, hepatitis A virus, immunoglobulin M, C, increase in anti-hepatitis B virus related to previous hepatitis B infection, and D, HAV IgG. This one should be easy because we just covered this concept. Yes. Hepatitis A is diagnosed by the presence of your hepatitis A virus, immunoglobulin M, IgM, remember. All right, our group member spotlight for today is Esther Jean-Baptiste. She's from Osceola County. She strongly identifies with her Haitian heritage. Her family's actually from Haiti, and Creole was her first language. She loves traveling. It's one of her passions. She's been to Haiti, Panama, Quebec, South Africa, and England. She studied wine while she was living in New Orleans, so she's a wine lover. Her favorite TV shows are Friends, Frasier, and Insecure. I actually have never seen any of those TV shows, so I'm not familiar with them. She's a believer of the natural hair movement, so shout out to Shea Moisture. Okay. And then she got her BS in psychology and her master's in public health from USF. So go Bulls. Love you, Esther. And we have some people saying go Gators. So we'll give the Gators their little, the little spotlight. So this is our beautiful Esther right here. This is the Haitian flag. This is one of the statutes. Ay bendito. Sometimes my English, it's so Creole is your first language, Esther, but Spanish was my first language. I actually lived in Colombia till I was 10. So there's times when I speak and like my Spanish just comes out so thick. So for week 4, our action items, I need your practice questions. I need your practice questions for Module 1. They are due on September 26th by close of business. Don't play with me. I just got my last practice 1 exam. Listen, guys, I need to know what we need to improve on, and don't be discouraged. So some of the questions in this specific practice questions are on chapters that we didn't go over, right? So it may not necessarily be something that we went over, but I'm not thinking I want to prepare them for these little, 50 question or 25 question sections of the exam. I'm trying to think like bigger picture, preparing you for the exam as a whole, not necessarily just these sections. But if there are concepts that you are not understanding, you need to make sure that you're going back and reviewing. This is supplemental to your own studying, okay? Your readings are going to be chapters 10, 11, and 12, and you need to make sure you take good notes. Okay, so that is it for today. I am going to just let one of the videos play that I was previously talking about. So if you guys have some extra time to stick around and watch the video now, you can go ahead and stay. If you do not and you need to get off, then thanks for joining me this beautiful Friday. I hope you'll have a great weekend. Hope you have some good, a good dinner and that you have a great time. But yeah, I'm gonna play that video now so that you guys are able to get a little bit more education on your gram-negative Enterobacteriaceae. And that's pretty much it. So let me disconnect this so that we can all listen to it together. Okay, guys, it's the microphone is not working, so you guys are just gonna have to watch it on your own. I apologize. But yes, okay, so we are done. You guys have a great weekend. Bye-bye.